Good afternoon, and welcome to the next edition of the Rheumatology Nurse Practice live Google Hangout. And we want to thank everyone for joining us today or watching this video as far as a replay. We've actually been getting great traffic on our replay videos, which are all hosted on our website. I'm Kevin Lyons. I'm the Executive Director of Rheumatology Nurses Society, and we're a nonprofit nursing association for rheumatology nurses and healthcare professionals. And we want to welcome you today. This series is a Google Hangout series for the Rheumatology Nurse Practice, which is a unique initiative that the Rheumatology Nurses Society, or RNS, actually facilitates. It's an initiative that consists of Google Hangouts like this, as well as live regional meetings. We were just in a great meeting in Seattle, Washington last week with Iris and Jackie Fitz. We also do a rheumatology nurse practice publication, which is an evidence-based peer-reviewed publication, which you can actually receive for free if you go to our website at rnsnurse.org. And you can find us on Facebook and Twitter as well. And just give us your address and we'll add you to the mailing list. It's a great resource that we have out there. And we'd also like to thank our sponsor today. This is all founded by a medical education grant from Pfizer. We also have some other grants in the process for upcoming editions, but this series is actually provided by Pfizer, and we want to thank them for their support. This is an unbranded presentation, and we are the authors and creators of the content. So today we're going to be focusing on, if we drop back a slide real quick, we're going to be focusing on RA and comorbid conditions. And the focus is on cardiovascular disease as it relates to those. Our faculty today is the president of RNS, Iris Zink, and she is a nurse practitioner out of Lansing, Michigan. We also have Betsy Kirchner, or Elizabeth Kirchner. She's a nurse practitioner at the Cleveland Clinic. She is our education and curriculum chair for the board of directors for the RNS. And we're super pleased to have a special guest, Catherine Gambino. She's a nurse practitioner in preventive cardiovascular disease. And we're excited to have this great panelist, and without further ado, we'd love to jump into the topics. But before we do, we would love to hear your questions. We have 3 ways of asking questions. You can use the Q&A feature within the Google Hangout on Air platform. We also monitor our Twitter account under the hashtag of RMP16, or Rheumatology Nurse Practice 16, and we'll be looking for questions there. And you can also text your questions to the Google Voice text line at 267-689-8495. If you're watching this broadcast later and we're not live, we do invite you to go to our website, and there's a Contact Us tab. And if you submit questions there, we will distribute those to our key opinion leaders and our content experts, and we'd love to try to reach back out to you. So now, without further ado, we'd love to turn it over to our panelists, and I'd like to hand it over to Iris Zink, president of the RNS.
Hi, everyone. Welcome to the Google Hangout today. The next edition that you should be receiving any day now is on managing cardiovascular disease in patients with rheumatoid arthritis. We all know how important this is. We all know that the risk is double in this population of patients for cardiovascular disease. And then there was just another article about 6 times the risk of cardiovascular disease in patients post-operatively who have rheumatoid arthritis. So today we're going to try to figure out how to be preventative and manage this disease with the help of Kathy, our content expert when it comes to cardiology and rheumatoid arthritis. Go ahead.
Oh, I think this is my part.
Oh, sorry. Sorry about that.
Okay. All right, so what I was tasked with was to go through our current edition here, which I have a little early copy, and pick something out that I want to talk about today. So our RNP newsletters, sometimes they're more heavy on the clinical side, the patient side, education side. So I thought for this one I would talk a little bit about patient education for RA and cardiovascular disease. Like as Iris said, we all know or should know what's going on with the risk factors, but the patients need to know. And so how do we best get that to them, that information to them? First of all, the patient has to be ready to hear this. They have to be ready to engage. If they just got hit with a diagnosis of RA, it's probably not the best time to say, oh, and by the way, here's another huge issue. So wait for them to be ready. Wait for a good opportunity, not too long, but let them get over the shock of the initial diagnosis, or maybe getting used to a new medicine or whatever's going on. And when they're ready to hear it, then we can start talking about the difference between the risk factors that they can control and the risk factors they can't control. So you can ease their mind a little bit and say, they can't change their gender, their age, their family history, or the fact that they have RA, but there are things they can do to modify their risk in terms of their activity level, their tobacco use, their weight, and how controlled their RA is. That's a very important one. A lot of patients are stoic and they say, well, I have pain and I'll just go through the pain, but we need to let them know that it's not just pain. There's inflammation going on. That inflammation is through their whole body, not just their joints, and it's important for their whole body to get their RA under control. So in terms of education and risk reduction, it's just like anything else. You choose your battles. If the patient seems more willing to talk about increasing their exercise, but not necessarily changing their diet drastically right now, great. Let's tackle one thing at a time. If it's exercise right now, that's what they're willing to do, then do that. Set reasonable goals with the patient and tell them, they're not going to lose 30 pounds in 2 months, and that's okay. We don't want them to. So set reasonable goals so they're not disappointed. They don't just drop out of the whole program. Strategy we use a lot in our department is, I don't know if there's a real name for it. We call it the one thing strategy. We say just pick one thing that you can do. If it's cutting out smoking or let's say cutting out smoking, then we say, all right, so for the next week you're not going to smoke after 8 p.m. And when they get to that one thing, they get that one thing accomplished, then the next time they come in, it's another thing. Now you're not going to smoke before noon. And gradually you just pick one thing. That's all they have to focus on. And if they can get through that, then they can hopefully make strides towards lowering their risk. And then the last thing is to consider outside help. I think you can go forward here, Scott. Let's see what the next slide has. Okay. Consider outside help because, in a nutshell, inflammation is bad. Inflammation is bad. I already talked a little bit about this. It's bad for your joints. It's bad for your heart. It's bad for pretty much anything. So you need outside help to manage the inflammation. Go ahead, Scott. Scott. Okay. So we need outside help a lot of times to manage this because it's just overwhelming for the patient. It's overwhelming for us. We sometimes don't have half an hour to talk to the patients about nutrition, exercise, medications for cardiovascular disease. So, maybe a nutrition consult, maybe a physical therapy consult to get the ball rolling. Now, the question then is, how far do we take this in rheumatology? We're rheumatology nurses. So how far should we go down this road before we call in the pros from Dover? The pros from Dover, for those of you who don't know, go ahead, Scott. It's my big moment. Scott. Those are the pros from Dover. Anybody who's seen the movie MASH, when you need an expert, you call in the pros from Dover. Okay, thank you for indulging me, Scott. You can go back now. In our case, right now, our pro from Dover is Kathy Gambino. So Kathy, you tell us. I always wanted to know, how far should we go? Should we just talk to them and then send them to you? Should we try a first-line medication for cholesterol or something and then send them to you? When do you want to see these patients? You tell us.
Well, what we've done actually is set up, which is probably where our names first got introduced to each other. We actually have an automatic referral system with rheumatology that every patient with that diagnosis comes to us. And, it does depend on your area's comfort level, and do you have time in your visits, and do you have the expertise, and do you feel comfortable starting to manage all the risk factors on top of the things you're doing? Because when you say, do you have an extra 30 minutes to cover that? We do. Like, that is basically what we do. When this person would come to us, we would go through, which I'll talk about a little later in a case study, the whole assessment and evaluation. And a physician usually typically initially does that, and then the patients are managed chronically, as in your situation too, by a nurse practitioner who's going to spend their entire time following up on those risk factors, assessing for any signs and symptoms. So we have the time to talk with the patient and address those things, whether it's managing their cholesterol, talking about smoking cessation, talking about hypertension, talking about weight. We have specific programs for weight. We have exercise prescriptions. We have all the types of things, I guess, geared in place in a multidisciplinary program to address all these issues. So I guess you have to feel your patient.
You're okay with seeing them like right out of the gate. You're okay with, you got diagnosed with RA, and I'm going to take care of your RA over here in rheumatology, and by the way, we're going to set you up with preventive cardiology right out of the gate. That's
Well,
okay with you?
one thing I would say, Betsy, is remember when you had said you want to make sure they're accepting and maybe a little bit under their belt with the diagnosis of RA before you bring in the. So maybe when the person reaches the point where they have a comfort level with understanding there is a risk for cardiovascular disease, then that might be a good point. I mean, if they're never comfortable with RA, then at some point you have to bring them over anyways. But, you know, I don't know if that comfort level happens after a couple visits or 6 months, 4 months, maybe after their initial flare-up or whatever's managed. But the sooner they get in, the sooner they can focus on the time to make the lifestyle changes.
That's a good point. Okay, now, so the second point is more, I was going to ask Iris, what do you think? Should all patients, you know, we're talking about RA today, so we can focus on RA. Should all patients with screen for CVD, that part's easy. The second part is, how often and to what extent? How often do you screen them in your practice, Iris?
Well, you know, I'm in Michigan, so things are a little bit different down here. We don't have the Cleveland Clinic available to us. So we do a lot of education in our clinic because there's such a shortage of primary care up here. So we just do it. The patients see rheumatology, and then they may see another specialty, but they don't necessarily see their primary care, who's kind of usually the gatekeeper and the educator in terms of risks. So we do a lot of education, and I feel like you have to do the education over and over. And the other point that I wanted to make, too, was, you know, I had a patient today who's on her 4th medication for RA. She's still flaring. She's still not doing well. Her blood pressure today was like 160 over 105 because she's in so much pain. So I think even though the patients may not be in the comfort level with their disease state, we got to refer early on for cardiovascular concerns, because when they're flaring and their disease is not well controlled is the peak time for cardiovascular risk.
Okay.
That's true. I like that point too.
Okay, our third point here was alternative complementary therapies. Kathy, do you talk about that in your case study at all, or do you want to? Do either of you want to chime in now? Have you? What do you tell patients when they ask about alternative and complementary? And that could be anything from herbal supplements to multivitamins to yoga. You know, what kind of things do you tell? We'll start with Kathy. What kind of things do you tell them, Kathy?
Well, like there is no harm to taking a multivitamin. Sometimes patients come in with a million supplements from fish oil, you know, and there's validity for vitamin D. There's validity for, and actually there's studies right now out there like Strength actually looking at omega-3 in cardiovascular risk. Does it really lower risk? But we do use fish oil. We do use vitamin D. We do use a multivitamin. Antioxidants really don't have a role in cardiovascular disease, in risk reduction for cardiovascular disease. You know, patients will come in red yeast rice because that has some cholesterol lowering effect. So I guess it's good, I think, to be open with the patient, because sometimes there's a role for the standard medicine, and then there is a role for some of those. And you can't be black and white about it, but it just depends on what they're on, because you often have patients, too, that have like 10 supplements, and then they don't want to pay for their Zocor or their Lipitor. So it's a balance. I'm not sure, I mean, if that answered your question about these, like, the supplements. Totally. Okay,
yeah, just
complementary therapies,
like
yoga, aerobics, water aerobics. I might not be hitting all the ones you're thinking of. Like, we are open to those kind of things.
Okay.
There's also Pilates. You know, and it depends, too, on the patient's activity level, because if they're so sedentary or they're not moving around a lot, that might be the start to getting them in something more active in a group setting. So.
What about you, Iris? Do you recommend any, not recommend any? Do you encounter it very much up there in cold Michigan?
I think the most frustrating thing for me is there was an article a couple of years ago, Betsy, you're the queen of references, about fish oil helping the RA medications work. And so I have a lot of primary care physicians, when my patients actually see primary care physicians, that take them off their fish oil because they say it's not going to help their heart anyway. And I'm like, but it could be helping your Sjogren's, your dry eye, and your rheumatoid inflammation. So please go back on that. So I love fish oil. I think it helps a lot, especially with the patients that have overlapping Sjogren's and dryness, which is so common in our patient population. And our patients seem to like supplements because it empowers them to be able to have some control. It's certainly, I always talk to them about it, adjunct in addition to their other things, but I think that it makes them feel like they have some control over the situation.
Okay. So there's our postman over again. Now we're done. Do you guys want to do the case study now? Is that all right?
Yes.
Sure.
Please lead on.
Okay. So we'll wait. We'll let you. Okay, there you go. So here's a case study about a patient with RA that was referred to preventive cardiology, because that will give you a little idea about the course of the action with this patient. So this was a 50-year-old female patient referred to preventive cardiology for an overall risk screening and what we can do for this patient. She was diagnosed with RA about 5 years ago. She came to us with a blood pressure 142/90, a BMI of 29. She was a previous smoker but had quit. And she said she quit with rheumatology. She had basically no structured exercise or activity, and I think that some of the patients that come to us are timid at starting, or they're not moving around, or they have pain. So the easiest thing to do is to shut down and not do exercise or activity. You know, for some people, her lipids would be very borderline, not striking in any way. Her total cholesterol was 214, LDL 142, triglycerides 182, and HDL 40, but we would address that. And then she was basically in the insulin-resistant prediabetes category with a blood sugar of 102, hemoglobin A1C of 5.9. And we do treat prediabetes in our area. We don't wait necessarily till they become a diabetic. And the patient's husband was also present for her initial visit. And in our assessment, which is very thorough, he reported that she snores a lot and gasps at night. So that was our patient presentation. So now most of you, or some of you, might be thinking, why refer these patients to preventive cardiology? And we talked about this a little bit already, but they do have such a significant increased risk of cardiovascular events. I'm going to go through this because we did already mention that they have twice the risk of your typical normal person, which makes them equivalent to someone who has diabetes, who is typically 10 years older. Patients with RA have 6 times more likely to have an undiagnosed MI, sometimes because they're on analgesics, sometimes they're so used to chronic pain, they don't report angina symptoms. And we mentioned how CVD is a leading mortality in these patients. And then there are some similarities between the processes that occur with atherosclerosis and the processes occurring in inflammatory diseases, such as the upregulation of adhesion molecules, pro-inflammatory cytokinins, TNF, and the production of enzymes that help form your atherosclerotic plaque. So these are reasons, there's such similarities that promote atherosclerosis that these patients should be referred to us early on. So then what happens when you send that patient over? This is our part of our assessment with that patient. We obviously do medical, surgical, cardiovascular history review to find out their whole medical history. We do a physical exam. I mean, we are listening to their heart. We're looking for structural abnormalities. There are things like, we do an EKG as well. There are things like AV blocks, actually I think it's pericarditis and myocarditis that are common in patients with rheumatoid arthritis, but the atherosclerosis is the thing that really increases their morbidity and mortality. But physical exam is important. Review a symptom assessment, and I would just focus on looking for angina symptoms or angina equivalents, like a shortness of breath with activity, an atypical chest pain in a woman. We look at their lifestyle health behavior assessment. And again, this goes back to the smoking. What are they eating? Are they eating a lot of processed carbohydrates, things that promote insulin resistance? Are they eating trans fat? Are they incorporating like heart-healthy things with fiber in their diet? What is their family history? You know, we obviously do vitals, meds, allergies. We look at their labs, and you saw their cholesterol, glucose, and we draw a lot of non-traditional markers of risk that might be uncommon to you, but like Lp(a), MPO, plaque, and these are labs that actually show or correlate with eventual cardiovascular risk. So you can kind of get a big picture of what someone's picture of risk is. And then we screen for other risk factors, like you saw the sleep apnea. We look at diabetes in pregnancy, polycystic ovarian syndrome, and things that some people wouldn't think of, menopausal status, etc. Okay, so some points for discussion, and maybe I'll throw it out to you guys. So we talked about the, and I don't know if it's easier to go back to the slide on the patient, but what sorts of interventions would you guys suggest for this patient? and I obviously can fill it all in, but what would you think we would do to reduce her future risk of cardiovascular disease?
Go ahead, Betsy.
Okay.
You want to go back to that slide with the patient on it, patient presentation, or is it?
No, that'd be good.
That highlights some of our issues right there.
Well, for me, and this wouldn't be the case for primary care, maybe or other departments, but for Iris and for me, the easiest thing would be the low-hanging fruit, which would be make sure her RA is controlled. I think that goes a long way in preventing, controlling the inflammation and preventing any cardiovascular events. So, however you want to do it, however you're measuring disease activity, whether it's labs or DAS28s or the other things we use in rheumatology, MRIs, X-rays, just make sure the RA is controlled. So that would be number one on my list, even though I know that might not be number one on the cardiologist list, but I kind of figure the cardiologist can handle the cardiology part.
And that's great.
Sorry, go ahead, Kathy.
Oh, I'm sorry. I said one of our key things is telling them to follow up with you guys.
Oh, thanks.
And
Iris, you're more like comprehensive lady up there, so what would you do for this patient?
Okay, so from our end on this patient, I mean, she's already quit smoking, but we want to reinforce the importance of that. And you can see her blood pressure is borderline, and some people might say, well, that's just typical for an office visit, but we would want to follow up on that and either have her come back for a blood pressure check, look at her blood pressures in rheumatology, have her do home monitoring, and maybe add a diuretic or something, because we don't want her borderline controlled. We want her well controlled. And then there's, we actually start people on metformin for pre-diabetes, especially when they're a BMI of 29 and there's a lot of insulin resistance going on. So we would do that with her. We would send her for an exercise prescription, which actually she'd get a stress test it's just a basic stress test to show us her activity level, and we would work with her on writing a program out for her.
Cool.
We can also calculate weight loss in there, like how many minutes she has to do to actually bring her weight down. She would see the dietitian. We'd probably send her for a sleep eval if she was like gasping and snoring and overweight.
For sure.
We would likely consider adding a statin based on her risk and for her LDL,
right?
Because that's one of the the meds that carries the significant reduction in risk. In all the studies, any patients on statins had lower event rate than not. And we would consider aspirin on her based on her risk, probably before other people would. Let's see. Oh, another important part is educating her on signs and symptoms of angina or chest pain. Because, again, those people in the studies tended not to recognize their symptoms. They have a lot of pain anyway, and then symptoms can be atypical. And actually, that stress test we do for the exercise is like an initial rule-out evaluation as well.
So, Kathy, you mentioned aspirin. So that's one of our big questions over in rheumatology is patients come to us, from preventive cardiology or the cardiologist if they've already had an event, and they're on aspirin, and we need them to please be on a non-steroidal, and now we're increasing their bleeding risk and everything. So how would we balance that out?
Yeah, we do. Do they, because some of them are on a QD non-steroidal, right? They take it on a regular basis.
Yeah, many of them are.
I know. Well, some of them, then they
using naproxen.
Okay. And this lady, I think, is on Etodolac or something. But they do end up on both. I mean, we do a baby aspirin, and we educate them to eat.
Okay.
Food. Take it. Like, don't take it before your meal. Take it when your stomach's full, like immediately afterward. Only in with the largest meal of the day. We educate them on any symptoms of bleeding gums, bleeding this, stomach irritation that they have to call us. But we do have a lot of people on aspirin, and I guess the keeping them on a baby, especially if they're on an NSAID. Some of our patients take 162 if they have some of those other markers of risk, like an elevated Lp(a), because that promotes blood clotting. So RA patients are usually on the lowest dose, but you're right, it is a concern, but I guess we're trying to balance those risks and benefits.
Okay.
Absolutely. I agree completely. We usually have our patients on an NSAID and aspirin too, and I understand the GI risk associated with that, but I also understand that the cardiovascular risk is the big thing. And I think it's really education, like you said, both of you, but women don't understand that for women it's not going to be the chest pain down the arm, that it may be just an increase in fatigue level, which again you have to weigh, is that the RA or is that really cardiovascular, where I'm just so profoundly fatigued I just want to go lay down, and that's why so many women, you know, have death associated with cardiovascular risk. So is that how you teach them, or how do you do it, Kathy?
No, I agree. It can be like vague symptoms, like a little shortness of breath, or not, you know, just like not tolerating their walk like they used to, but they can't explain why, or fatigue, you know, or a weird arm symptom, or something that you wouldn't necessarily. And if they did describe any of those symptoms, I would likely order an echo or thallium. I would choose an echo first because of the lower radiation, but just because their EKGs can cause false positive too. Right. So, but yeah, it's a lot of education and spending time, I guess, listening to them in the appointment. You know, you're not going to ask them just like, do you have any chest pain? You know, it's going to be all the time-consuming discussion, but it's important.
Betsy, can you hold up the cover of the next edition again? So in the next edition, the nice thing about it is that we actually do have case studies in the back. Betsy, myself, write case studies in the back of all of these, and then we usually have someone else write a case study as well, like Sherry or Jackie Fitz. But it really does help my brain to understand things when you have a case study that really illustrates what happens when the patient has RA and cardiovascular disease, and then the risks, just as a good reminder to all of us how dangerous this disease really is.
I know when you have a diabetic patient, you right away think cardiovascular disease, but I don't think people think that about lupus or RA patients at all.
Yes,
I guess we should, do you want me to go back real quick to those other two discussion points?
Absolutely.
So how can you establish a good working relationship between rheumatology and cardiology? And I guess this depends highly on how your clinic is located, because at the Cleveland Clinic, things can be unusual compared to other settings, like your setting in Michigan, Iris. You know, our section had, and because we're preventive cardiology, we seek to reach out to populations, like even those with psoriasis and dermatology, or bariatrics, or diabetes. We seek to reach out to those populations because we want them to come to us, because there are people that we can work with and lower their risk. They seek to benefit from our services. So, you know, you need physicians that are going to do that, or that are educated and are aware of the risk. Then we set up a best practice alert, which is like a flag in our medical system that will pop up on the rheumatology side and say, hey, this patient stands to benefit from prevention, consider referring, and they can simply hit a button, I believe still, and it goes through on the worksheet and goes to the front desk and they're scheduled. So you're making things so easy. You know, otherwise it's a lot of education to all the professional groups, you know, that they're aware of the risk and they find processes to get these patients referred.
Right.
Yep.
I find that I have to teach the cardiologists up here all the time, because they'll send the patients back and they didn't do any testing on the patients, and I'm like, do you understand? You don't get it. It's like if I sent you a obese diabetic with high cholesterol. It's the same risk profile, so it's really just education. So hopefully we'll get the message out with this Google Hangout and the upcoming newsletter. Kevin, do we have any questions from the audience?
Sure, we actually have a couple of points of discussion. Whoa, sounds like we have a lot of echo too. And this kind of ties into a little bit of the conversation you're having is, you know, in a great system like the Cleveland Clinic, you have so many resources at your fingertips, where in contrast, you know, Iris, she has to work a network of between primary care and specialty and cardiology for reviews. Are there any best practices to coordinate that in a non-hospital system or non-academic system, you know, place? I mean, Iris, how do you overcome some of those issues?
I'm really lucky. There's a great big cardiology group in town where all the cardiologists belong to the group, and I am very good friends with the nurse over there, so it'd be like your Betsy to your Catherine relationship. I just literally call up Alan every time I have a patient who I'm concerned about and say, don't forget about the cardiovascular risk, and I've typed it into the EMR note. Make sure the cardiologist reads the note to really understand that the risks associated with this patient. So I'm always going on and on. But if I didn't have that point guard over the cardiology office, I really just don't feel like the education is there with the cardiologist still about the level of risk. So it does take a little extra effort.
So it sounds like it's a great networking opportunity to meet the other specialists in the area, to know when, or know who they are, and have some of the informal education, but maybe even something that RNS can step in to do some other education on.
Absolutely.
Another piece of it is how, and I apologize for the echo, I'm not sure why that's coming through. How can you best, I'm sorry, how should we talk to a patient about taking I'm going to blow the word.
How about just calling it Xeljanz? We can call it Xeljanz.
There we go. And the possibility of raising cholesterol levels.
So what do you do about this, Betsy and Catherine? I want to know, because you talk to your patients about your risk for cardiovascular disease is double that somebody who doesn't have RA, but I'm going to put you on this medication and it could raise your cholesterol. So how do you approach that with a patient?
Well, I'm kind of mean. I sometimes use it. A lot of patients want to get off the injectable or infusible biologics, either because of cost or an inconvenience or whatever reason, and they say that they see on TV or whatever, they hear about this pill you can take now. And I say, oh, that would be great, except that you're 30 pounds overweight, and we can't afford to increase your cholesterol. So if it's for sure absolutely the only choice they have, then you'd never withhold treatment from a patient, of course, who needs it. But if it's just one of several options, we really can't afford to give them another cardiovascular risk if they have some already that are uncontrolled. So that might be the thing that finally gets them to go see Kathy when we've been begging them to go for a year. But it is, you have to take it into account. It's not trivial. You need to monitor it pretty closely.
We have some issues like that too, where it's like you have to treat something, and sometimes you're going to end up treating the other thing that's in response.
Mm-hmm.
It's true.
Thank you, ladies.
Sure.
And then one final one is, how do we find time during the patient visit to have a discussion about their cardiovascular disease with all of the other priorities that we need to focus on?
I don't know how we can't, because as nurse practitioners, we're always taught to think of the most likely and the most lethal. So, when the patient comes in telling you symptoms, what's the most likely and what's the most lethal? That's how rheumatoid arthritis is. So if the disease is well controlled, our risk goes down all over the place. But certainly you got to think about, most likely the disease is going to come under control, but the most lethal thing that they're going to die from is the disease being poorly controlled, doubling their cardiovascular risk. So I think we have to talk about it all the time. Do you have another point?
I agree. I run late a lot. That's how I find the time. I try to explain to every patient, I'm sorry, I'm 5-10 minutes late, but I'll spend just as much time with you. And sometimes it's a follow-up phone call, a couple days later to say we didn't get a chance to really go over this in as much detail, but now I have your cholesterol panel back, from the lab, and let's talk about this.
I think, Betsy, you said a good point about one thing. Even when you said when you're making goals with the patient, is maybe like you hit on one risk factor at a time, or find a strategy where you're nipping away, slowly at their big picture, because it is challenging. We even, run out of, some of the patients we manage have both heart disease and a whole ton of risk factors, and so of course you have to manage the heart disease and the symptoms, and you run out of time doing everything, but you try to nip away at the big picture.
Well done, ladies. Thank you so much. Kevin, you want to close us out, unless there's any other questions?
Did we lose Kevin? You can close us out, Iris.
Hey, Kevin, how's it going? All right, thank you so much for joining the Google Hangout. Just like Kevin said, if you have any questions or you view this later when we're not live, please do push the contact us button on our website, and we will try to get those questions answered. And thank you so much for joining the Google Hangout today. I can't wait to see you. Bye. See you soon.